Dr. Christopher Boone, who I would like now to introduce, and will as soon as I get my notes out here. And I have to take some notes because his vitae is so long and so distinguished that well, Rebecca will tell me that I'm out of time, and so I have to be succinct, and it's not easy. Dr. Boone is Vice President and Global Head of Health Economics and Outcomes Research at a company called AbbVie, and he's on the adjunct faculty of NYU's Robert Wagner School of Public Service, the other end of Broadway. Before he was at AbbVie, he was at Pfizer as Vice President and Head of Global Medical Epidemiology and Big Data Analysis, and he was Vice President and Global Head of Real-World Data and Analytics there. Oh, and along the way, I should mention, he co-founded a few startup companies, too. He's on some very influential national committees. I'm just giving you a very abridged list here, including Department of Health and Human Services, Federal IT Policy Committee, Robert Wood Johnson Foundation's Data Across Sectors for Health Initiative, and he's on the Interoperability Committee of the National Quality Forum. What a CV, and what an honor it is to have you here, Dr. Boone. So let me turn things over to you, and thanks for being here.
Good morning, everybody. Come on, let's try it again. Good morning, everybody. Good morning. I actually have to pull up my notes because it honestly keeps me honest, and if I don't, I tend to ramble a bit. So we'll go with that. First, let me start by saying how delighted I am to be with you all here today. It's a great honor and it's a great privilege to discuss something that I think is very, very important, and we're going to get to that. But I do want to acknowledge the professionalism, the hospitality of the team, whether it's Rebecca, Dr. Brown, Ruta, Angela, everyone that's part of the planning and coordination committee for this. Can we give them a round of applause for this meeting? Thank you. Secondly, I just want to share with you a brief story before we get started on how we did it. When I originally got the invitation from Dr. Brown, he said, it may be a good idea for us to chat. And I said, oh, sure, great. I mean, we can always have a pre-meeting conversation. It was meant to sort of level set on expectations. So we got on the video call, the Zoom call. We were having a great discussion. And then he goes, Chris, I got one last question for you. And I said, yeah, shoot. And he goes, do you believe in free speech? And like most of you, it was like, well, what does he mean by that? And of course, I responded with, absolutely. And he goes, well, do you mind giving one? And so anyway, no. He didn't say that. That didn't happen. I'm just joking. But that's usually how it goes when you work at universities. All right, so before we get started, let me just give you a disclaimer here. I am an employee of AbbVie, NYU. I serve on the boards of PCORI and a company called Global Medical Response, which is actually a medical transportation company. And these views that are expressed are clearly my own. So they're not representative of any of the institutions that I'm affiliated with in formal or informal capacities. I'm going to just take you a little bit over, I'm going to say it's a journey of sorts. And this will be all the things that we cover. First thing I'll do is give you an introduction of, a brief introduction of my company, AbbVie, the function, the division that I lead within AbbVie. Then I'll talk a little bit about myself, and then we'll jump into, better understanding some of the health outcomes that are specific to the U.S., right? We could go global. We're going to talk about the U.S. in comparison to some other high-income countries. We'll talk about the state of the trial, which is the state of the clinical trial and where we are and why this reimagination is necessary. Talk a little bit about public policy and its influence and how things are evolving quite rapidly. I'm then going to wrap it up with my own personal moonshots that I hope that many of you would join me in sort of conquering, if you want to use that term. But just so you know, I mean, AbbVie, one of the largest biopharmaceutical companies in the world. I think we're like 2 or 3. Most people know the company for Humira, which was one of the best-selling drugs of all time, but treated many, many, many diseases. It's like a miracle drug. Other folks may know Botox. I don't know if any of you know it, but it is one of the therapies for AbbVie, and then of course you can see all the others that are there too. The organization that I lead, Health Economics and Outcomes Research, this is our remit. Now you can see this particular division. It exists in all pharmaceutical companies or medical device companies. The remit does vary. So if you see one, you've only seen one, technically. But for us, we're focused on building innovative, scalable, and proactive evidence generation strategies tailored to the product value that accelerate patient access to treatments by using real-world evidence, economic modeling techniques, and patient experience data. Typically, this is used to sort of assist with treatment decisions, supporting label expansion as we add new indications or disease states that these particular therapies can be used for, maximizing registration, coverage, and reimbursement. It's usually covered across these 5 areas, whereas patient experience, real-world effectiveness, health economics, customer-centric or patient-centric research, and then innovative research methodology, which we'll talk more about. This is my incredibly talented leadership team that, sort of allows me to do the things that I do because they're all so well talented. You have Seppi Varan, who leads HEOR for immunology and oncology. You have Carol Bao, who leads neuroscience, eye care, and general medicine, HEOR. And then we have our vice president for patient-centered outcomes research is Robin Carson. Mike Eady is a vice president, what we call the Center for Health Economics and Real-World Evidence. Brian Meisner leads our, what we call US Geography, but basically our value-based strategies team. And then Raj Mehta, who's my sort of right-hand chief of staff, and he leads our operations. But this is interesting, right? Now, I typically have a standard way of introducing myself, but I thought I would be sort of innovative. And so I would try ChatGPT. Now, this is my first ever prompt in ChatGPT. So now I know a lot more now. I'm still a novice, but I was really a novice when I did this. So look at, you can just tell this. Can you tell me who Chris Boone is from AbbVie? And I thought I would use it, right? So it's not cheating because I actually, posted. But anyway, the point is. So it said, now surprisingly, it did come back with, Chris Boone is the vice president and global head of health economics and outcomes research at AbbVie, a pharmaceutical company that focuses on developing drugs for various health conditions. As head of HEOR, Chris is responsible for leading a team that conducts research to demonstrate the value of AbbVie's drugs to patients, healthcare providers, and payers. His team's work includes assessing the clinical and economic impact of AbbVie's drugs, as well as developing real-world evidence to support their use. Chris has extensive experience in health economics and outcomes research and has authored numerous articles and book chapters on the topic. Prior to joining AbbVie, Chris has various leadership positions at other pharmaceutical companies and academic institutions. That's really good, isn't it? I mean, I was like, well, that's better than what I could do. So then I said, all right, so then I said, well, where did Chris Boone work prior to AbbVie? It said, I'm not aware of which specific Chris Boone you're referring to, as there may be multiple people with that name. Now, this is in the same conversation I'm having with ChatGPT, but he goes, however, if you're referring to the Chris Boone who is the vice president and global head of health economics and outcomes research at AbbVie, he previously worked at Pfizer, where he held the position of vice president and head of real-world data and analytics. That is all true. But then it says, prior to that, he worked at United Biosource Corporation as the senior vice president of real-world evidence and at PharMetrics as vice president of research and data operations. That is not true. So this is truly a garbage in, garbage out situation. The point of it is if you use ChatGPT, just know that everything is not necessarily completely accurate. But this is my standard way of introducing myself. So I went back to the old school way because ChatGPT just doesn't work for me. And so you can see where I spent the majority of my career in biopharma, health systems, nonprofits, and consulting firms. I moonlight as a professor, as was mentioned by Dr. Brown. I served on several influential boards, including PCORI. I'm a Dallas, Texas born and raised. If you can't hear the slight draw, I try to mask it as best I can. But as a husband and father, #1 Dallas Cowboys fan, which I think is incredibly important. And Oh, come on, don't laugh too hard. I know it's been a while, but anyway, so I'm a patient advocate, a social scientist, health informaticist, and what some like to call a futurist. But I actually get described, if you ask people, as a number of things. You get this personal brand thing that they got going on nowadays. And many say innovator, transformational leader, and visionary. But the visionary thing is always very interesting to me. And I tell people that visionary is like, it's sort of a bittersweet, or it's like a gift and a curse, right? And I'm going to tell you why. So I was actually listening to a sermon by this guy, Bishop T.D. Jackson, down in Dallas, and he described about the plight of the visionary. And I thought it encapsulated everything that I feel when I say that it's the gift and the curse. He says it's a painful thing to be a visionary, because a visionary sees what shall be, but wakes up to deal with what is. As I think about the healthcare system as it currently stands, in my head, from my perspective, I have a vision on the way that I think things should be. But we're going to talk about the way things really are. Now, this gets to one of the stories that's extremely near and dear to my heart. Now, I actually discovered Lori Becklin, this is the picture you see, back in 2015, and it's because she penned an article in the LA Times it's really titled, "As I Lay Dying," and it is a true situation. Now, what you should know about Lori, because it's extremely important, is that she was she was obviously a wife, a mother, a friend to very many. On the professional side, she was very, very accomplished. She was a Pulitzer Prize-winning journalist with the LA Times. She wrote about the LA riots, the El Salvadoran death squads that were happening, just a number of stories and books that she read. But this is the thing, in 1996, Lori had done everything right. She had well over 20 mammographies, but she discovered a lump in her breast, right? Went to the doctor, said, okay, very common stage 1 breast cancer, so very treatable. 5 years later, they actually found, she went to her doctor and they tell her, oh, you're in the clear, live a great life. 13 years later from her initial diagnosis, they actually gave her a call and said, we need to talk. And basically they discovered that she then had stage 4 breast cancer, and it had metastasized to now her bones, her liver, her brain, and other major organs. Basically, it was, as she would describe it in her article, a death sentence. So with the last few months of her life, she decided to pen this article, which essentially became a call to action. Now, I was leading an organization called the Health Data Consortium at the time. It was based in DC. We were about sort of democratizing and innovating around health data. So that's why this article caught my attention. And I used it as an inspiration to sort of carry her vision forward and to keep her memory alive, because I thought that it was so remarkable that this woman, even in her last days, chose to share her knowledge, share her perspective, and really demand change for people that she herself would never benefit from. One of the excerpts from her article was this, and I'm going to read this to you because it sets the groundwork for a lot of the things that we're going to talk today. She says, we now know that breast cancer is not one disease. What works for one person might not for another. There is no one cure. We are each, in effect, one-person clinical trials. Yet, the knowledge generated from those trials will die with us because there is no comprehensive database of metastatic breast cancer patients, their characteristics, and what treatments did and didn't help them. She says, in the big data era, this void is criminal. Consider what Wall Street does. Even the tiniest companies can see how much stock they sell. Compare themselves to cohorts. Review history. Predict trends. Why can't we create such a database for cancer patients so that we can all learn from patient experiences and make more educated decisions on what treatments will extend and improve lives? This is her call to action to all of us. So, as we continue on, this quote is actually from Nancy Dreyer, who's now the former retired chief science officer at IQVIA, She quoted, and I love this quote, I've always used it because I think she really encapsulates everything that Lori was referencing, but also what real-world evidence really is. And real-world evidence, and because I'm going to use this term a lot, and I'm going to hear me say RWE, so just so you know what it is, provides insights about how patients respond to treatments in typical care settings, which may differ from responses in the controlled environment of a randomized clinical trial. RWE can be used to show regulators, payers, and physicians that a treatment is right for a specific condition and type of patient, and that it is better than available treatments in some ways such as effectiveness, safety, or tolerability. RWE can also dash the hopes of one's promising treatments when benefits don't translate to real-world settings. So imagine that you got randomized clinical trial and the data and the evidence that we generate there. Then you have the non-controlled or uncontrolled environment that we now know as the real world when you're actually going to see your doctors. And that is the situation that Lori was in. As we, if you don't remember anything, it's always important to give you a takeaway, right? So what I want you to know from my talk, in addition to Lori Becklin and going to read that article, As I Lay Dying, I also want you to know that the ability to generate compelling evidence throughout the life cycle of a drug or a device therapy is increasingly important. As we move from a world where evidence generation is predominantly generated from RCTs or randomized clinical trials to launch to one where ongoing generation of the right evidence, which includes RCTs, real-world evidence, and patient experience data, is critical to delivering on the therapy's full potential, whether that is measured in safety and effectiveness of the therapy or patient access to the therapy. Now, we're going to jump into this very interesting topic. How many of you guys know who Bill Parcells is? Is that just, am I dating myself? Okay, just for those who don't know. Huh? Okay, well, I'm just making sure. So Bill Parcells, just for some who don't know, NFL Hall of Fame coach. He did coach the Giants. We don't hold that against him, but he coached the Cowboys when he made what I'm about to tell you. And at the time, the Cowboys were, I mean, we were stacked, right? We had all the star players and all this stuff, but we sucked, right? And so he was being interviewed, and he goes, well, how do you keep losing with a team that's so talented? His response was, we are what our record says we are. Basically, he's saying our record sucks, so therefore we suck, right? I want you to keep that quote in mind as you think about the US healthcare system and the data that I'm about to share with you. No offense, you all are very talented, but the record is what it is. It's per Bill Parcells. All right, first thing you should know is that at approximately 3.35 trillion, hold on, I'm screwing myself up here. I'm trying to look at my notes. At approximately 3.35 trillion, the US healthcare system represents about 17.8% of GDP. Now, this cohort of other high-income countries that you see, where I have Mexico, Korea, Finland, Australia, Japan, the Netherlands, Sweden, Canada, Switzerland, the UK, France, Germany, you can see where the US is, 17.8%, where that cohort average across these high-income countries is 11.3. That's point number one. Now, you're going to say, oh, this pharmaceutical guy's up here, well, it's because of drug pricing, right? Well, according to this, the US is among the lowest when it comes to pharmaceutical spend as a percentage of overall healthcare spend. The cohort average is 13.3. We sit at 11. Mexico is actually the highest with 21.5. Next, we'll look at US life expectancy at birth, which is less than other high-income countries. Now, I looked at it from 2001 to where we are in 2021. That line that you see on the bottom here is the US. And you can see over the last 3 years, whether we're looking at 2019, we're at 79.1 for life expectancies, 2020, 77.4, and 77.2 for 2021. The highest, this orange line at the top, is Japan. And you can see that they're, in 2021, they were 84.8. The issue is that the average is 82.09, and we are 77.2. All right? Now, this is another thing, and this is sort of goes back to Lori Becklin. The U.S. has among the highest rates of screening for breast cancer. 77% of women ages 50 to 69 are actually screened for breast cancer, and that was she. So in that regard, we're doing pretty well. But another thing where we're not doing so well is 30% of U.S. adults are the most likely to have multiple chronic conditions, which account for more than 85% of the overall healthcare cost. Another area that is particularly interesting is that this whole notion of healthcare deserts, right? And what I mean by that is an area that lacks access to pharmacies, primary care providers, hospitals, hospital beds, trauma centers, and/or low-cost, health centers or community health centers, basically. So according to GoodRx, they found in their research that more than 80% of U.S. counties lack adequate healthcare infrastructure, and it contributes to underrepresentation in clinical research. There was another study that was done where the researcher looked at LA County specifically and looked at all the census tracts within LA County and said, I want to better understand this issue of pharmacy deserts. There's actually a pharmacy desert where pharmacies are not necessarily present. And she found that 25% of LA County, believe it or not, major urban area, actually lacked or was a pharmacy desert, which means they had access to no medicines, literally. Now, granted, most of these, what she also found is that most of these areas, that 25%, were in areas that were impoverished, that had higher crime. Population was probably lower on the health literacy scale than some of the other parts of the county. And so what you found is that this area, this population of folks who probably don't have as much as others, did not even have access to the medicines in this particular area. The question is why? Why do we have all these issues, and why do we have such poor outcomes in the U.S. relative to other high-income countries? Well, these are several documented, but also my perspective reasons. Well, there's obviously an access issue. We just said over 80% of the country actually does not have access to, whether it be providers and pharmacies and so on and so forth. There's obviously a big inequality and poverty issue. Social economics does matter in one's ability to have good health. Lifestyle factors matter. This fragmented healthcare system that we have matters. And then, of course, there's a high healthcare cost challenge with that, too. The next part of our journey, we're going to I want to give you a deeper sense of clinical trials and where we face with that, and of course, diverse representation in trials, which you hear a lot about nowadays, especially after the pandemic. I think it's important, so we'll talk about that. This quote was made by Dr. Janet Woodcock, who's, I don't believe, is no longer with the FDA, but she was at the FDA at the time. She made a quote that says, "I believe the clinical trial system is broken. I do not believe it serves the interest of the patients." She's not the only one that feels that way. Dr. Califf, who's the current commissioner of the FDA, said our clinical research evidence generation system is too slow and expensive. It's leading to a vast gap between what we need to know about health interventions and what we actually know. And what he's really referring to is this fact that prior to what you're seeing with the vaccines in the pandemic, drug discovery and development are expensive, and it's a high-risk investment. It usually takes about 14 years and $2.6 billion on average to actually make this happen. The interesting about it is that only 10% or less than actually go from human trials and actually make it to the pharmacy. So there's a lot of drugs that you never see because it's either it's a failed trial or it's a failed drug that prohibits that particular therapy from making it to the market. Ongoing challenges that we continuously see with clinical trials, and this is where it gets a little murky, right? And why you see such failed trials and failed or missed opportunities with getting those drugs to the pharmacy, is that honestly 54% of clinical investigators participate in one research study and they never do it again. Either they find it very laborious, they don't feel like they have the support, the infrastructure, you name it. Less than 5% of all patients participate in clinical trials. And there's reasons for that, but we'll talk about it. 49% of patients drop out before the study actually completes. So even if they do commit to it, half of them drop out. 48% of trial sites miss enrollment targets, which again affects an ability to complete a trial. And the average distance a patient lives from a clinical trial site is 50 miles. Now that affects participant diversity, hard to recruit subpopulations, patient retention, and cost efficiencies, quite frankly. Representative trials, or diversity in clinical trials, still remains an issue. Now, people always say, well, you show the slide, it shouldn't matter. Well, it does matter, because when you look at what clinical trial participation is, 61% of the population is white American, but 84% of clinical trial participants are white, relative to black folks who are 12% of the population and 5% of the clinical trial participants, and even worse for the Hispanic population, which is 16% of the population and less than 1% of clinical trial participants. Now, why do you ask? I mean, why is that important? It shouldn't matter. We're all human, right? Well, it does matter. And there's plenty of studies that show that therapies do not have the same response in certain subpopulations as they do in others. And so that's the reason why that matters. But then it comes back to, well, when you think about people and their ability to sort of be involved in a clinical trial, there was a survey that was done that asked, which clinical trial information source would you go to first? 62.3% of the people said they rely on their provider to tell them about trials. The other 22.4% said they do Google searches, literally, right? So, and of course, everyone else falls down there. And of course, drug companies, we only get 0.3%. So if I'm telling you about a trial, you're not going to listen to me. That's basically what that means. But then the next question was, have you ever been invited to a clinical trial? 87% said no. They had never been invited, so they're not even aware that trials are out there. These investigational therapies that may help or extend their lives. And then, of course, 8.9% said yes, and of that 8.9% that did say yes, half of them actually said yes to participating in the trial. The other half said no, and it's for a number of reasons. 80% of patients included in genome-wide association studies are European descent, which actually worsens when it comes to disparities as we move more into this clinical genomic world where we're taking genetic data and clinical data in order to better understand who would be responsive to certain therapies and who aren't. So here are some recommendations for people as you think about clinical trials. And actually, after I developed this list, I scrapped it because I started looking at the data again. I was like, this doesn't even matter. The real key to success for increasing diversity in clinical trials, first thing you need to do is engage the patients themselves. You have to make them aware. You have to make them partners, if you will, in clinical research. Second thing I would say, then you have to go to where they are, right? There's so many what we call healthcare deserts across the country. We have to build infrastructure in these areas that don't have it otherwise. And then you start to do these other things, reducing the barriers and all this other data-related stuff. But it starts with viewing patients as partners, and that's a cultural and a mind shift from where we are as it currently stands. But let's talk about policy. When it comes to policy, the reality is that public policy, I always say there's two things that really drive innovation and transformation in our society. The first thing is technology, as you all see, with the ChatGPT and your smartphones and all these other things. The other is public policy, believe it or not. And what we've seen, even when it comes to public policy, to address many of the issues you see here, whether it be the pace of scientific innovation, rising clinical development costs, increasing availability of data as we get into these privacy concerns, importance of patient centricity, and the emphasis on value, which is really around, well, we're putting all this money into the system, where are the clinical outcomes to be associated with it? Across the world, this sort of the only slide that I have that's dedicated to a global view, is that this issue of real-world evidence and big data and AI is not a US-centric issue. All of these countries that you see, all of these regulators are wrestling with this issue, and they're trying to elevate it. They're trying to accelerate this idea of utilizing big data ultimately to improve overall patient care and hopefully decrease the cost and the impact to the system. You see the FDA there, you see the EMA, you see the NMPA, which is in China, Health Canada, PMDA in Japan, the MHRA in the UK, and of course the Taiwan FDA. This is a list, and it's an eye chart, so I don't expect you to read it, but we can certainly give you the slides if you want it. It just shows all the key activities that have happened. But one of the things I want to bring your attention to is, look at this one here. 2007, and I'm old enough to remember this, I was one of the crazy people waiting in line for this thing called the iPhone. And it didn't do anything. You know, I got it and it had nothing on it. There was no app store, nothing, right? So it was just the iTunes device. But that was in 2007. It seems like forever ago. And then you also had that same year, Fitbit marketed its increased concept of wearable devices, right? This is just, 16 years ago. And then, of course, ISPOR actually, which is the International Society of Basic Outcomes Research, they defined this term real-world evidence, which did not become popularized really till 2015, 2016. So they had a work group, they defined it, and that's what happened. But now, if you fast forward to where we are now, we'll just go to 2017 to 2022, you can see all of the guidance around real-world evidence. So it took 10 years from here to get to here, right? And then once you had it here, now you see the accelerated use of real-world evidence. You guys following me on this? All right. So, but it did start. Now, we thought it was great. I've been an ambassador and an advocate for increased use of big data. I'm on record. My Twitter handle is called Data Hippie, for goodness sake. True, this is true, this is a fact. And so I've been talking about this idea of using big data for healthcare for a long time. I wouldn't say with little regard. I'm just going to say I haven't paid as much attention to addressing some of the issues that are associated with it. It has caused some problems, right? Privacy is one. Bias is another, and discriminatory practices. Transparency, or the lack thereof, continues to be an issue. And that's one of the issues we have in clinical trials too, is transparency to patients actually matters. People want to know what exactly goes on behind the steel curtain. Consent, telling people why you're doing it and what they're actually agreeing to is important, in layman's terms even, not legal documents. How many of you actually read the terms and conditions on any of the apps that you download from the App Store? Show of hands. Nobody. Everybody just says, I agree. Why? Because it's too complicated. You feel like you need a JD in order to decipher what it means. But that's what we run into with clinical trials and any of the clinical research that we do. Same challenge. Accountability, which means that in the UK it's being very progressive in this particular area of accountability, which means that with GDPR, they're saying, if you misuse AI and data to cause some form of harm to people, you are accountable. Right now, it's harder for us to do that in the US. And we're trying to do this almost on a state-by-state level. And then, of course, fairness is always a challenge. The US government, though, back to the US, is taking some steps to address these issues around data ethics. They have data protection laws, which, again, are not federal, so they are at the state level. California has its Consumer Privacy Act, where they're trying to address this issue. New York has a bill on the docket where they're trying to address this issue around privacy. We're seeing ethical guidelines come out through different federal agencies. The National Institute of Standards and Technology has released one that's out, that's publicly available. HHS has released an ethical framework that's about big data that's publicly available. Then you have this issue of oversight committees is another area. The FTC, which is about protecting the interests of American citizens, is also taking this issue of the ethical issues around big data very seriously. And then, of course, you have the Communications and Information Administration under Department of Commerce, who's also serving in an oversight capacity. Then there's data ethics training out there for people, because some people don't know what it is, and they don't know what to actually make of it. And so you have the NSF, who actually has training that's available in the DoD, which they probably should really think about. They got some other issues they're dealing with leaks. But of course, this is where we are. And so there is a concerted effort. And you're starting to see these ethical data ethics groups being propped up in the private sector with many other companies. The big tech companies have established those functions. I think they're trying to find what their remit is and really wrap their heads around it, because it is a complicated issue. All right, so now we're going to jump into my moonshot. It's always important, right? I didn't want to just give you this glimmer because you all seem like you're depressed now that we've talked about the record of the US healthcare system, and I wouldn't mean that. So now it's time for me to bring you back up. I think there's hope, and I do believe that we can certainly move this needle much further than we have in the past. So I'm going to give you my moonshots, but we're going to start here first. World Economic Forum actually publishes their Industrial Revolution periodicals, and the most recent one was the Fourth Industrial Revolution, which is where we are in right now, this whole digital era that we live in. And this is what they said about the healthcare industry. They said the healthcare industry is faced with the challenge of incorporating simultaneous advances in physical, biological, and digital technologies as the development of new diagnostic approaches and therapies coincides with a push to digitize patient records and capitalize on the wealth of information that can be gathered from wearable devices and implantable technologies. This is our challenge in the Fourth Industrial Revolution. But we've had some key advances over the last 25 years. We had the Human Genome Project, which was remarkably successful. You had targeted cancer therapies, immunotherapies that have been developed that certainly prolong the lives and improve the lives of many of the cancer patients. We've had this whole precision medicine, personalized medicine revolution that you're hearing a lot of things about. We're even 3D printing organs now, you know, which is something I would have never thought 20 plus years ago. There's the ubiquity of digital health, and then there's also health data, but now it's the resurgence of AI. Everything seems to be centered around AI these days. And speaking of AI, there was a team at MassGen who developed an AI model that uses routinely collected clinical brain images to detect Alzheimer's disease with a higher degree of accuracy than human reads of those scans. Then there's a group, same place, well, it's actually at MIT, where they developed a system that uses our AI to help predict the future risk of developing breast cancer. Now I'm going to go back to Lori Becklin. How do you think she would feel about this? Right? This is what she was demanding. This is what she was asking for. The next 25 years, though, you know, in addition to what the World Economic Forum said about all our challenges, we see this happening. So DNA sequencing of increasingly representative and diverse slice of the world's population, not just the US. Expanded use of digital technologies will enable the use of mass phenotyping, enabling longitudinal data that provides deeper understanding of the effects of nutrition, which is actually which has been determined as a very key determinant of overall health and disease. We will also continue down this path of digitization and virtualization, which will allow for storage and democratization, there's that word again, Dr. Brown's word, of larger data sets globally. And then, of course, precision therapy will increase significantly, but it'll be driven by all of us, people who are demanding personalized treatments or single-person clinical trials, as Lori said in her article back in 2015. The thing you should know about that article, it was actually published after she passed. So she wrote it, and it didn't release, and then they published it after she passed away, just so you know. So now we're at the point where we got 3 data moonshots. By the way, how are we doing on time? We're good? All right. So then we may have time for questions, I guess. All right. So I got 3 data moonshots that I've come up with that I would like to see to reimagine the sort of global clinical research enterprise in the future of drug development. Moonshot number 1 is to establish a robust clinical research infrastructure in sub-Saharan Africa to expand access to investigational therapies by 2033. We'll talk more about that and why I'm saying that. Moonshot number 2, integrate predictive medication into routine clinical practice using clinical genomic RWE by 2033. And the last one, of course, again, my inspiration in Lori, advance the science of N-of-1 trials, single-person trials, using digital twin and responsible AI for drug discovery and development by 2033. How's that sound? That sound really good? All right, well then you guys can do it. I just come up with ideas. I don't actually do the work anymore. But let's talk about moonshot number 1, why I said this. Sub-Saharan Africa, believe it or not, represents 1.18 billion people. 2,000 languages spoken, 46 countries, and it's the second most populous region in the world. Now I'm going to take you through some facts, so you're going to follow me here. We're going to start up here. It's projected to account for 25% of the world's population by 2050. Life expectancy at birth, remember we said it was like 78 for the US right now. For sub-Saharan Africa, 61. Poverty head count ration is at $2.15 a day. They have recently, or at least it's supposed to be launching this year, their own regulatory body, which they've never had, equivalent to the EMA or the FDA, and they're calling it the African Medicines Agency, the regulatory agency for the African Union, and it's expected to be operationalized this year. Another thing you should know about this particular region is that a total of 2,861 clinical trials, or 4% of the global total of trials, were conducted in this region between Jan 2020 and December 2021. And roughly 50% of those are done in the following countries, as you would imagine, the more developed nations in that region: South Africa, Nigeria, Uganda, Kenya, and Tanzania. Now, I know you're thinking, you're like, well, they have problems over there, right? That's how you're all looking at me with the skepticism. I feel it. And I'm going to acknowledge it. So it's there, right? We're over there. Some countries may not have established regulatory agencies like the FDA or the EMA. We know that. Some countries don't have the infrastructure, whether it be facilities, staff, technology, supply chain. We recognize that. Clinical trial sponsors have been less likely to fund trials in this region. That's a problem. And then, of course, there's ethical concerns with trials, specifically the exploitation of the vulnerable populations in this country, which goes back to the ethical issues and the consent issues that we were talking about earlier. But there are benefits to doing this in this country, or in this region, on this continent. There access to diverse patient populations. There's reduced lower cost of labor and equipment and facilities, increased recruitment potential with the large and growing population, improved health outcomes as participants have access to now to these therapies that they wouldn't otherwise have access to. And then there's an ability to build the research capability and train many of these healthcare professionals in that region so that they can treat this very growing and fast-growing population of folks. You guys still with me? You think this is feasible? Again, do it. Now, this time you say, no, I don't know about that being feasible. Now I'm starting to get the reality. Okay, that's why it's a moonshot. Second thing, integrate predictive medication into routine clinical practice using clinical genomic RWE by 2033. This is my theory. We take care of people from the cradle to the grave, right? We do now have the ability to sort of create longitudinal records of patients because now we have all the digital technologies to do it through our electronic health records and other platforms that we use. What we must do is actually sequence their DNA at birth. Now, some of you are like, oh my gosh, I don't want my stuff sequenced. But that's where the benefit of clinical genomic information becomes valuable, because now we know what works for you and only you, or even patients that look like you. So that's something to do by 2033. And then, of course, this advance in the science of N-of-1 trials in honor of Lori Becklin. by using digital twins and AI was not discussed as common technologies when she wrote her article. But the idea of creating a digital replica of each of us and then essentially doing in silico experiments where you're trying these therapies in a sort of in silico environment and you're not exposing the people is actually, to me, the ethical thing to do. And then you can actually simulate, if you will, how patients actually respond to many of these. Are you guys following me still? Can you do it? I'm getting a lot of that. The yeses are minimal now. What happened to the excitement? All right. So here it is, call to action. I'm asking each of you, your entrepreneurs, your intrapreneurs, your policymakers, your administrators, your professors, your whomever you are, I don't care. If you contribute to the system, this is an official call to action to each one of you that I need your help in order to achieve these moonshots, as well as address many of the other issues that we have in this healthcare system. The quote you see up here says, just do nothing. And then the other says, it is impossible. But if you read it all the way through, just do it. Nothing is impossible. That concludes my talk. Sure.
So folks, if anyone has a question, they want to walk to either of the microphones, please do so.
Good.
We have time for a few questions.
It's a great presentation. Thanks so much. It was a great overview. I have a couple of things that came to mind amongst the many. Yeah, a couple of things that came to mind. One of the last points you mentioned, sequencing the DNA all the way from birth to the end.
Yeah.
Which we all, as I'm a provider and I'm also on the hospital side and all of that. The biggest fear that I feel, that a lot of people also feel, that is if that information is not protected, which we hope it is, the payers dominate the landscape in U.S. healthcare system. And the fear is if they get their hands on some of this information and they still we know they control the healthcare market, what will they do with it if they do get it? And that's a lot of people think that way. Maybe as the generations come up, they might feel more secure about that information getting out there. So I think that's a fear because the payers are definitely an issue here. And then the other part is probably another discussion, is why is it that the U.S. healthcare system is so siloed, and why is it that there's such resistance to change? And we wouldn't see that as much on the business side in the private sector as there is in the public sector sort of hospitals, whether they're nonprofit or profit. And why is it that culture is so difficult to tackle?
Yeah. Well, the first question around the ethical concerns with DNA, the privacy issues, is fair. And the other sort of group that I would add in addition to payers is employers. And any other group that can effectively discriminate against someone because of their own health status. I think that many of the ethical frameworks that you see here are really meant, and they're sort of being constructed to address that. You got to raise the education level of folks of what is possible and that, no, you cannot do this. Then you have to hold them accountable to it, right? And that's what I appreciate what the EU is doing around this issue of developing ultimately public policy around what you can and cannot do with an individual's health data, as well as utilizing AI technology to enable that. So I think that the interesting dynamic that we always have is that public policy cannot keep up with the pace of technological advancements or scientific advancement. So I do think that it is a legitimate concern, hence my reason for it as a moonshot. But I think the benefits to me outweigh the negatives, the cons, right? Because I mean, what we're essentially doing is personalizing therapies now to individuals based on their DNA. And once you do it once, you only need to do it once. You don't have to continuously sequence a single person's DNA. And I think that once we have that, then you'll find that the benefits definitely outweigh the cons. But the payer concern, the employer concern are all very legitimate.
Right, and when that model changes, if it does, then we'll feel much more secure about doing. The medical side of it is there's not even a question about it, you know, in terms of outcomes. And then the culture of the healthcare system in this country.
That's a tough one. It's perverse incentives, so I would say, honestly. There hasn't really been, the incentive structure has not been, I'll say up to snuff, if you will, to sort of incentivize that level of change and transformation. But that's transformation in any organization, industry, or in this case, our healthcare system, right? There's so many parties who benefit from the status quo. And it's not until you see that level of rise, almost like a groundswell of people who are demanding that level of change. Hence, when I had in the slide, precision therapy will be driven not by any particular institution or organization, but by patients demanding, just like Lori did, that you give me therapies that you know work for me. I don't care about what works for the masses, right? And so that is the world that we're going to get into, because honestly, you can do it. It's just a matter of people being made aware that it's possible.
Thank you.
Hey, Angel.
I was curious from your perspective. I think one of the things that I felt would have been interesting to hear your take is sort of the work that's happening. Actually, something that Dr. Brown intimated to, which is the intersection between the public health perspective and sort of the acute medicine. And I know one of the things that we're both in the same industry, so one of the things that I think we've been able to see is more of a long-term perspective for patients when we're thinking about trying to capture and quantify the value of interventions and therapies for patients. We're also thinking about where in the patient journey do we initiate that prevention piece, or can we start thinking about screening and those sorts of pieces.
Yeah.
So I'm curious from your perspective, if you want to share, like, I guess for the audience, a little bit more about where you see the industry particularly pivoting towards that message a little bit more, and how you're integrating it into some of the programs that you oversee as an executive in that space.
Yeah, I think prevention and I will say early detection are keys. I mean, I think that a lot of the messaging, and you're sort of tapping into a number of things when you ask that question. I mean, I think part of it is this issue of social determinants, which we now recognize as a real issue. And so hence the partnership between those two sectors within the field. And the whole, like, I know many of you have heard it, what your zip code tells you more than your genetic code, that whole theory, which is very much very true. And so I think that, it's interesting from a biopharma perspective, the assumption is that you want the world to stay unhealthy because you make more money. Is that what people think? That's fair. But no, it's not fair. I don't want people to stay unhealthy. I don't think that that's true at all. I think that the world is starting to move to this space where we recognize that prevention is certainly one way, as we talk about the chronic conditions, which has been a big thing. Some diseases are unavoidable, whether they're genetic, whether they're just acquired because of the environment that you live in, however that works. But I think that what I'm seeing the world shift to is we're saying that there is more rare disease, which is not necessarily true. It's back to what Lori said. It's just individuals and your own disease state, your own environment, your own genetics, your own family history, your own nutrition levels. All these things become increasingly important. And the more we can educate people about the smoking, the diets, the exercise, the active living, these sorts of things, the better off that we will be. And I think that now, with that partnership between sort of the social public health agencies and many of the acute care facilities and docs in these local communities is important, because it used to be that the relationship between a patient and a doc was very paternalistic, right? You just do as I say. You come in, feel something, do as I say, go off. Now it requires, even when I go see my doc, I'm giving him as much information about myself and actually proposing alternatives, which he may or may not like, more so than we've ever done before, because I know my own health status. I know what I'll actually be compliant doing. I also know where my situation, and I think that's the case for a lot of people. The ability to be able to sort of self-advocate or advocate on behalf of your loved ones is the new sort of medication that we all need, right? And that is education and awareness. Right time? Thanks. Do I keep the same? All right.
Thank you.
All right. I'm going to sit right here for a
Thank you again,
second.
Dr. Boone.
Yeah.
You know, I was looking up at in high school, I worked in a lab mapping the human genome. So it is quite remarkable to think of how short our time frame has been in terms of these kinds of innovations and technologies. But thanks for helping us to look forward. And also setting the stage for the rest of this conference. I'm Rebecca Sale. For people who don't know me, I work here in the Department of Health Policy and Management. My job right now is to put you on a break. And so let's come back together in about 10 minutes, back in the same room for our morning panel. Thank you.